السلام عليكم. انا دكتور ايهاب عثمان، استاذ طب وجراحه عيون كليه الطب جامعه الاسكندريه. برحب بكم في قسم العيون او طب وجراحه عيون جامعه اسكندريه، ومحاضره النهارده هتكون عن الليد ان شاء الله. محاضره النهارده هتناول فيها انترودكشن للاناتومي بتاع الليد، وهنتكلم عن بعض الديزيزز، وهنتكمل في محاضرات ثانيه مع بعض الزملاء الاخرين ان شاء الله. بسم الله. اول حاجه نتكلم عليها النهارده anatomy of the lid. الليد عندنا there are two lids, one upper lid one lower lid. Okay. These two lids fuse at the inner canthus. Inner canthus يعني التقاء الupper and lower lid في الناحيه الداخليه اللي هي جنب المناخير. And the outer canthus هو التقاء الupper والlower lid في الناحيه الخارجيه ناحيه الاذن. اوكي. المسافه اللي موجوده بين الupper والlower lid اسمها البالبيبرال fissure. So now we have the upper and lower lids. These lids fuse at the inner canthus, and this is the junction close to the nose, and they fuse at the outer canthus, and this is the junction close to the ear. The space between the upper and lower lid is called the palpebral fissure. The lid has a very important function in our life to protect the eye. So the first function of the lid is protection of the eye. بيقولوا العين عليها حارس. The lid protects the eye by several mechanisms. It is a mechanical barrier towards any incoming foreign bodies or trauma. There is a reflex blinking towards any harming object towards the eye, and the lids plays a very important role in the eye lubrication by spreading some of the materials needed for the watering of the eye or keeping the eye moist, and also by spreading this material on the surface of the eye, surface of the cornea, to keep it always moist. So the function of the lid is mainly protection of the eye by the mechanical barrier or the nature of the lids when the lids are closed, and by the reflex blinking towards any incoming object. And the second function is moisturing of the eye or keeping the eye moist by secreting some of the material needed for the tear film, and by the reflex blinking or the blinking that keeps the eye moist by the spreading of the tear film on the surface of the cornea and surface of the eye. So let's now talk about the layers of the eye. We have 5 layers of the eye. The first eyelid, the first layer is the skin. Underneath the skin there is a layer of subcutaneous tissue which is very thin, and underneath that there's a layer of muscle, and the main muscle present in the lid is called the orbicularis oculi, and the fourth layer is called the tarsus, and the tarsus is the skeleton or the thing that keeps the eyelid having its texture and its shape. This is called the tarsus, and included in the tarsus are glands called meibomian glands. These glands secrete meibum, which is a sort of an oily-like material that floats on the surface of the tear film to keep the tear film from evaporation. And the last layer is called the conjunctiva, covering the lid from the inside, and this is the layer that is in contact with the cornea and contact with the sclera. So the lid have 5 layers. The first layer is called the skin, second layer is called the subcutaneous tissue, the third layer is called the muscle layer or the orbicularis oculi, the fourth layer is called the tarsus with its meibomian gland, and the fifth layer is called the conjunctiva. If you look here, this is the meibomian gland. You can see the lower lid is everted downward, and you can see the meibomian glands are oriented vertically on the lower lid as we see here. Let's talk about the lid margin. The lid margin is anterior lid margin, which is rounded in shape, and this anterior lid margin has hair follicles, and these hair follicles are called the lashes. The lashes are directed upward and outward in the upper lid, and are directed downward and outward in the lower lid. The lashes function to keep the eye from any harmful object that might enter the eye, like dust or foreign bodies floating or flying in the air, and it acts like a filter for the eye. And the posterior lid margin is vertical or perpendicular to the surface of the globe. You can see the anterior lid margin is rounded and the posterior lid margin is vertical. This vertical lid margin, or this sharp lid margin, 90 degrees lid margin, is very important for keeping the eye moist by spreading an equal tear film on the surface of the cornea and the surface of the eye globe. If you look at the lid margin itself here, you can find here these are the orifices of the meibomian gland, and this line is called the white line. Okay, and in front of this white line, between this white line or the orifice of meibomian gland and the lash line, there is a line called the gray line, and it's here put in the color gray. Okay, this gray line is not a line that is anatomically present except for the demarcation between the anterior lamella of the eyelid, which is composed of the skin, subcutaneous, and muscle, and the posterior lamella of the eyelid, which is composed of the tarsus and the conjunctiva. So if you look here, this is the gray line and this is the white line. So again, this is the gray line that's present here, okay, separating the anterior lamella of the eyelid, which is the skin, subcutaneous tissue, and the muscle layer. As you can see, this is the plane of the gray line, and this is anatomical plane for our surgical intervention in some of the lid cases, because this plane is relatively avascular, so we can enter in this plane, separating the anterior lamella from the posterior lamella. And the posterior lamella is composed of the tarsus and the conjunctiva. Again, we have two lines. The first line is called the meibomian, or the white line, which is composed of the meibomian gland orifice present here, and in front of it is the gray line, which is an anatomical plane that present between the anterior lamella and the posterior lamella of the eyelid. Okay. For the muscles of the eyelid, we have one muscle that closes the eyelid. As you can see here, this is a muscle called orbicularis oculi, and this orbicularis oculi surrounds or encircles the eye. So when this muscle contracts, it closes the eyelid. The orbicularis oculi is one of the important muscles to close the eyelid, or it's the only muscle to close the eyelid, and it is supplied by the facial nerve. What about the muscles opening the eyelid? We have here what's called the levator muscle. Okay, this is the levator muscle. You can see here, this muscle levates the eyelid, so-called levator muscle. Okay, this muscle levates the eyelid, and this is supplied by the third cranial nerve. We're going to go back in the previous slide. You can see here, these muscles here are the orbicularis oculi, okay, and this is the aponeurosis of the levator muscle. It is inserted on the top of the tarsus and on the front surface of the tarsus. So when this levator muscle pulls or contracts, it pulls the eyelid upward, and in the lower lid pulls the eyelid down to open the eyelid. So this is the muscle for opening the eyelid, called levator palpebri superioris, or levator muscle, and the muscle closes the eyelid is called the ocularis muscle, or orbicularis oculi muscle, orbicularis oculi muscle. So this is the orbicularis and this is the levator muscle. But actually we have two other muscles that elevate the eyelid. The second one is called the frontalis muscle. The frontalis muscle is the muscle present in the forehead here, and when this muscle contracts, it contracts upward and pulls, or helps in pulling the eyelid upward. So this muscle is called the frontalis muscle. So we have one muscle closing the eyelid called orbicularis oculi, and we have up to now two muscles opening the eyelid, which is called levator palpebri superioris and the frontalis muscle. Okay, so we have now, up to now, two muscles to open the eyelid. The most important is the levator palpebri superioris, supplied by the third cranial nerve, and this is the frontalis muscle. There is another muscle that helps to elevate the eyelid. It's called the Horner muscle. Horner muscle is supplied by sympathetic nerve supply, and it helps also to pull the upper eyelid upward. This is a very weak muscle present just in front of the conjunctiva, as you can see here. This is called the molar's muscle. So this is the tarsus, and this is the molar muscle present on the top of the tarsus, just underneath the conjunctiva. And the Horner muscle is supplied by the sympathetic nerve supply. So if you are going to talk muscles closing the eyelid, it is the orbicularis oculi muscle. Muscles opening the eyelid, it's called the levator palpebri superioris, the frontalis muscle, and the Horner muscle. What about the eyelid diseases we're going to be talking about today? We're going to talk about the infectious or inflammatory eyelid diseases. There is also the malposition of the eyelid, and we also have the neoplasia of the eyelid. My talk today is going to be about the infectious and inflammatory process of the eyelid and part of the malposition of the eyelid. So, if we're going to talk about the infectious or inflammatory process of the eyelid, there is either localized inflammation that can be acute in the form of hordeolum externum and hordeolum internum. These are acute inflammatory processes present in the eyelid that are localized. We have also chronic localized inflammation of the eyelid, which is called the chalazion. What about inflammation of the lid margin itself, which is called blepharitis? So inflammation of the lid margin is called blepharitis. We have anterior blepharitis and posterior blepharitis, and we'll be talking about all these now. First, hordeolum externum. The other name of it is sty. How to define it? It is an acute suppurative inflammation of the follicle of the lash or the associated gland of Zeiss. Let's explain this line. There is a hair follicle, which is the lash in the eyelid, and there is an also associated gland around the lash, helps to nourish the lash and helps in keeping it in a healthy state, which is called gland of Zeiss. If there is an acute suppurative, means creating pus, inflammatory process in this follicle, this is called a stye. The organism is usually Staphylococcus aureus. Incidence, it is very common in children and young adults. How can we say the clinical picture? It is an acute inflammation. We know from the pathology, inflammation is defined by as redness, hotness, swelling, and pain, and loss of function. So if we're going to say inflammation, we have to fulfill these items. Redness, you can see here, the eye is red, as you can see in this slide. It is painful, okay, and it is tender when we touch it. So pain is without touching the eyelid, and tender is when we touch the eyelid. And there is suppuration. Here you can see this is the stye, and this is the stye. This is suppuration or pus that is present on the lid margin around the lash follicle. It can point anteriorly through the skin on the lid margin, usually around the lash. Okay, the pain is usually dull, throbbing pain. Okay, so there is redness, there is hotness, there is pain, and there is swelling. This is the sign of an acute inflammatory process in the follicle or the hair lash present in the eyelid. This is called hordeolum externum. How do we treat it? Topical antibiotic ointment on the lesion. Oral antibiotics are rarely needed because this inflammation is usually mild and it is usually small, so we apply topical antibiotic eye ointment. The pus can be evacuated by epilation of the, epilation means removal of the lash, okay, of the affected lash. So when you epilate this lash, as if you are opening a very small opening around the pus, and the pus can come out from this opening of the lash root itself, okay. It's important to know that never ever squeeze an inflammation or a pus in the face, because this is the dangerous area of the face. Again, this is the dangerous area of the face, from the eyelids around the mouth up to the upper lip. This triangle is called dangerous area of the face. So any infection in this area, if you squeeze it, you can spread the infection through the blood and goes to the cavernous sinus in the brain and cause serious life-threatening condition. So never squeeze this pus. To prevent recurrence, treat the associated local disease, example blepharitis. So blepharitis can cause frequent presence of stye in the lashes because of the inflammatory nature of this stye. What about the hordeolum internum? Again, this is an acute inflammation, but in this point in the meibomian gland. So in the stye, we said inflammation around the lash follicle or the gland of Zeiss, but here this inflammation of the meibomian gland. It's usually again caused by the same organism, Staphylococcus aureus. Incidence, it is the second most common infection of the eyelid. The clinical picture, it is painful. Again, signs of inflammation, redness, hotness, pain, swelling, loss of function. So this eye is painful, it is red, as you can see there is redness, and it is tender. When I touch it, there is tender swelling. It can be separated from the lid margin by a normal non-inflamed tissue. As you can see here from the inside, this is the hordeolum internum from the inside. You can see there is normal tissue between it and the lid margin. Again here, this is the swelling and this is the inflamed swelling. You can see the lid margin is normal and there is normal tissue separating from the calazion itself, or sorry, from the hordeolum internum itself. The pain is dull and throbbing pain. How do we treat it? Warm compresses with gentle massage. Please, dear students, when you hear the word warm compresses, compresses means kamadat or warm foments. Please don't use a moist cotton. Don't use a moist tissue. Don't use a moist handkerchief. Anything that is moist will help the spread of infection, and this organism can pass from one area of the lid to another. So when we say compresses or foments, they are equal to each other. The compresses and foments should be dry. What do I mean by dry? Use a bottle, fill it with warm water or hot water that patient can tolerate it, and close the bottle and dry the surface and put it on the eyelid from the outside. So in this case, the eyelid is going to be heated by the warmth in the bottle itself without the moisture of the tissue or the handkerchief. Okay? And again, don't use, as our grandparents told us, kamadat shay or tea foments. This will help the spread of infection more and more. So this is warm compresses. Why do we put warm? The warmth helps to increase the blood flow to this area and helps to eradicate the organism or eradicate the infection from the area by the natural antibodies or antibiotics present in our body. Okay, and why do we say gentle massage? Because when I apply gentle massage by the bottle as I roll it on the eyelid, this helps to the flow of the lipid in the meibomian gland can help to be excreted and helps to be eradicating the infection. Again, topical antibiotic eye drops or ointment are prescribed only if the lesion is pointing on the palpebral conjunctiva, because this is the route of absorption of the antibiotic eye drops or ointment through the conjunctiva if there is pointing, as we've seen in the previous slide. Oral anti-gram positive antibiotic and analgesics are prescribed. As we said that this swelling present here, we have to give it antibiotics present through the blood. It will pass through the blood, and oral administration can help to resolve this condition. Okay, and why we give analgesic? Because we said there is pain. It should never be incised during active inflammation unless it forms an abscess. If there is an abscess, incise it. If there is no abscess, give the medical treatment, and it would help to resolve the condition. If you see here, this is the stye or the hordeolum externum affecting the lash root, and this is the hordeolum internum from the inner side sparing the lid margin. So this is the hordeolum internum and this is the hordeolum externum. So the third thing is the chronic inflammation. These previous two, hordeolum internum and hordeolum externum, are acute inflammatory process, and as we said, acute inflammation, there is pain, redness, hotness, swelling, and loss of function. So what about the chronic inflammatory process? This is called chalazion. Again, chalazion is inflammation, chronic inflammation in the meibomian gland, and so it's called meibomian cyst. How to define it? It is sterile. Sterile means there is no organism. In the previous two cases, hordeolum internum and externum, there was an infecting organism, which was usually the Staphylococcus aureus. But for the chalazion, it is a sterile inflammatory process. There is no organism. Chronic. The previous two were acute. This is chronic. Granulomatous inflammatory lesion. Why is it granulomatous? Because it is chronic. Of the meibomian gland, caused by retained sebaceous secretion. So what is the function of the meibomian gland? It secretes, as I said before, oily material that covers the tear film to retard the evaporation of the tears. So this oily is sebaceous-like material. So if it is retained, because the gland of the meibomian is occluded by any reason, so there is no exit for this sebaceous or this oily material to the outer surface. So it's going to be retained inside the meibomian gland, and the retention will lead to swelling and swelling and swelling of the meibomian gland, and the chronicity will lead to granulomatous reaction and causing the chalazion. The incidence, it is the most common benign, it's not a tumor, non-neoplastic lesion of the eyelid, commonly associated with posterior or seborrheic blepharitis. Seborrheic blepharitis means people with oily skin nature, like people having dandruff in the hair, people having oily skin of the face. This is the seborrhea. Okay. The clinical picture, there will be symptoms gradually. This is a chronic lesion, so this will be gradually enlarging, painless, rounded nodule, as you see here. Again, there is no signs of acute inflammation. It is not painful, and it is not acute, it is gradually enlarging. Okay. It is a firm nodule within the tarsal plate. An associated conjunctiva granuloma may be present. Okay. If this chalazion thins out the tarsus, it's going to be causing granuloma affecting the conjunctival site. How do we treat it? There are two types. Medical treatment, warm compresses. Again, when we say warm compresses in the eye, warm, dry compresses. Don't use moist compresses. With gentle massage several times per day will help resolution, especially if the case is early. Okay? Antibiotic and steroid topical treatment can be applied. What about the surgical treatment? Intralesional steroid injection. We can inject inside the cyst itself steroids. The steroid will help to resolve the inflammation and help to reduce the size of the granuloma, which is the chalazion itself. However, steroid injection can cause some problems such as depigmentation of the skin around the chalazion. It can cause some problem inside the eye, because if this is repeated, it can cause raised intraocular pressure and so. Again, the second line of treatment surgical is incision. As you can see, this is called a collision forceps. We press on the collision and we incise the collision vertically. Do you remember the slide that I showed you when I showed you my bombing glands? They are oriented vertically, perpendicular to the lid margin. So if I incise it vertically, I will cut 1 or 2 glands only. But if I incise it horizontally, I will cut several bombing glands, destroying them. So when I incise the collision, I incise it vertically so that there will be damage only to 1 or 2 bombing glands. And when we incise it from the conjunctival side. As you can see, this is the forceps and the lid is everted so that I can incise it from the conjunctival side. It's very important in a case of recurrent collision in the same position. So if I have a position of a collision, say in the left upper lid in this area, and I incise it and it was treated, after a couple of months it recurred again in the same area and recurred again. So this is a recurrent collision in the same site, especially in the elderly. This can be a sign of underlying malignancy called meibomian gland carcinoma or sebaceous gland adenocarcinoma. Okay, we talked about the localized inflammatory swellings in the lid. We're going to now talk about the lid margin inflammation, which is called blepharitis. It is defined as inflammation of the lid margin that involves lashes and their associated glands. Inflammation, again, redness, hotness, swelling, and so on, so on. So, as we said before, this is an acute inflammation. However, this is chronic inflammation. Okay, it can be either anterior blepharitis affecting the area surrounding the bases of the eyelashes, and this can be either seborrheic type or staphylococcal or ulcerative type. So, blepharitis is rather a chronic inflammatory process, can affect the anterior part of the lid, either in the form of seborrheic blepharitis or staphylococcal or ulcerative blepharitis. These are the types of the anterior blepharitis. Or this blepharitis can be a posterior blepharitis. Okay, what about the seborrheic anterior blepharitis? It is associated with generalized seborrheic dermatitis. As you said before, seborrhea means oily nature of the skin. Okay, it is characterized by hyperemia of the lid margin. As you can see, the lid is rather red. Hyperemia means redness. Okay, the presence of greasy, soft scales on the lashes. Take care of this nomenclature. Greasy, this is oily scales, okay? Soft, they are not dry. Greasy, soft scales of the lashes. And we have a characteristic, we say it calls matting of the lashes. Matting means every group of lashes are matted together. You can see here, these 5 or 4 lashes are matted together. These 5 are matted together. So this is called seborrheic anterior blepharitis. How do we treat it? By lid hygiene. Warm, dry compresses and lid scrubs. There are scrubs for the lid having some sort of a detergent material or something like a soapy material that removes this grease. Grease is oil, and if you want to remove oil, we need to use a soap material like. So if we're going to use a scrub with a soap material like to clean the lid, it will have to decrease the sebum or decrease the amount of grease on the lid margin and helps to resolve the seborrheic blepharitis. We use something called diluted baby shampoo. You all know the Johnson baby shampoo, which is called لا دموع بعد اليوم or no more tears. This diluted baby shampoo can be used around the lash follicles to clean the lashes, because this is not irritant to the eye if it enters inside the eye. Okay, again, we can use any soapy material to clean the lid margin, but any soap, if it enters the eye, it causes burning sensation of the eye because of the nature of the detergent or the soapy material itself. But if you use the Johnson baby shampoo, we can clean the lashes to remove the sebum or remove the greasy material, and if it enters the eye, it will not cause that burning sensation. Also, have to treat the associated scalp seborrhea, because it will lead to recurrence of the anterior blepharitis if it's not treated. The second type of the anterior blepharitis is called staphylococcal or ulcerative blepharitis. It is caused by Staph aureus or Staph epidermidis. The clinical picture, there may be some sort of ulceration of the lid margin. You can see there is some sort of notching in the lid margin. You can see some sort of notching in the lid margin here. Okay, they will be hard in the seborrheic. They were soft. Here will be hard because they are dry scales. The seborrheic blepharitis was called soft, greasy scales. Here they are called hard, dry scales. Where? Around the base of the lashes, called collarettes. So these scales around the lashes are called collarettes. As we've seen before, the seborrheic blepharitis, the lashes were matted together. Here the lashes are not matted together. So this is, again, the lashes are separated from each other, surrounded around the lash by hard, dry scales. The lashes will fall with scarring and notching of the lid margin. Dry eye is a common finding, okay? The complication can be sort of mother roses, trichiasis, and poliosis. So mother roses, as you see here in this slide, is loss or absence of the lash from the lid. This is called mother rose. You can see the lid has no lashes. Trichiasis means maldirection of the lashes. You can see these two lashes are maldirected, rubbing against the eye. And poliosis means whitening of the lash, as you can see here. So the complication can be mother roses, trichiasis, and poliosis. There can be recurrent styes. As we said here, there is inflammation by an organism around the lashes, so this can lead to recurrent styes. There will be chronic conjunctivitis because this dried scales, when it touches the conjunctiva, will lead to its irritation, will cause conjunctival inflammation called conjunctivitis. And flictins. Flictins means a nodule-like lesion, as you can see here in the conjunctiva, surrounded by vessels, okay, and this nodule is raised. This is due to inflammation of the conjunctiva and irritation of the conjunctiva. So these are the complications of staphylococcal ulcerative blepharitis. How do we treat it? Lid hygiene once more. We can use warm compresses. Warmth leads to more blood flow to the lid and helps to resolve any inflammation by this fresh blood carrying nutrients and carrying antibiotics and carrying anti-inflammatory to the inflamed area. And dry, as you said before, not to induce more inflammation and spread of infection. And you can use also lid scrubs with diluted baby shampoo. This is called lid hygiene. I would like to add something about lid hygiene, especially for young ladies and female patients who use lots of makeup. This makeup can be irritant, especially if it's of bad quality. And this powder-like or anything like the makeup can cause plugging or closure of the Maudon gland orifice and lead to blepharitis and inflammation of the lids. So when you're going to use makeup, please make sure that you remove the makeup quite well and don't use it for long times. Keep it limited to the time of severe need, okay? We can use topical medication in the form of fusidic acid and azithromycin. These are antibiotics acting on the Staph aureus and Staph epidermidis. Systemic antibiotics in the form of tetracycline, doxycycline, or azithromycin can also be used. We use these systemic antibiotics for two reasons. The first reason is because they're antibiotics and there's a sort of inflammation or infection in the staphylococcal blepharitis. The second thing that these antibiotics, especially tetracyclines, help to improve the quality of the meibomium or the sebum that is being secreted from the meibomian gland present in the tarsus. And finally, managing complication in the form of the mother roses, the poliosis, and so on. What about the posterior blepharitis? Before we start posterior blepharitis, it's also called meibomian gland dysfunction or MGD. We have to know the tear film is present in the form of 3 layers. The first layer is a mucus-like layer, and this is secreted by the goblet cells present around the limbus and in the conjunctiva. This mucus helps to adhere to the corneal surface. So this is the cornea, and mucin adheres to the corneal surface. Above this mucin, there is the tear film or the water part of the tear film. This is secreted by the accessory lacrimal glands, and in case of crying, secreted by the main lacrimal gland present in the upper lateral part of the orbit. So the tear film up to now has 2 layers. The mucin layer secreted by the goblet cells around the limbus, and the watery part secreted by the accessory lacrimal glands and also from the main lacrimal gland in cases of crying or reflex tearing. And the third layer is called the oil or the meibomian secretion. As I said before, meibomian glands secrete an oily-like material. This oily material floats on the surface of the water. As you know that the density of oil is much less than that of water, so it floats on the surface of water. So this helps to retard evaporation of this water and helps to maintain the eye moist. So if you have deficiency in this oily layer, the water will be evaporating quite frequently, or more common than the usual, and this will cause dry eye and irritation. So this posterior blepharitis is also known as meibomian gland dysfunction. This alteration and inspission. Inspission means it becomes more viscid or more cream-like or toothpaste-like. Okay, alteration and inspission of the meibomian gland secretion. So the secretion meibomians are no more oily-like; they are thicker in density. Okay, contributing to ocular surface irritation. As we said, this oil is important for moisturizing the eye. So if it is deficient or not functioning well, it will lead to irritation and increased tear evaporation and unstable tear film. It is more chronic and persistent condition than anterior blepharitis. It is something that patients have to live with for a long time. The symptoms, dry eye manifestation. What are dry eye manifestation? Foreign body sensation, frequent blinking, feeling that your eye is like adhering to the lid, especially when I wake up in the morning, I cannot open my eyes as if they are attached to the lid by Velcro tape. Okay, this is signs of the dry eye. There will also be recurrent chalasia. As you said, chalasia are in chronic inflammatory process in the meibomian gland. So the presence of meibomian gland dysfunction can help to lead to recurrent chalasia. The signs, there will be hyperemia, means redness of the posterior lid. Telangiectasia means abnormal vessels. As you can see here, these vessels are telangiectatic. They are not normal vessels of the posterior lid margin. So this is a picture of posterior blepharitis. There can be foamy discharge on the lid margin. This is a sign of dry eye or meibomian gland dysfunction. Foamy discharge, like the foam of a soap. Either excessive turbid meibomian gland can be seen on the surface of the tear film, or the tear meibomian gland can be inspissated and be like a toothpaste or plugging the meibomian gland orifices. You can see here, if we press on the lid margin, the meibomian gland should be oily like material. Here you can see it comes out like warm or like toothpaste coming from the container of the toothpaste. These are called inspissated meibomian gland secretions. You can see they are very thick and very viscid, and these are not normal in consistency and will not function properly to keep the eye moist. We can see here the sign of pouting or projection of the meibomian gland orifices because the secretions are retained inside it. Okay. How do we treat it? Again, eyelid hygiene, warm compresses, lid scrubs with diluted baby shampoo. We know this and we've learned it. Oral tetracycline or doxycycline. Why? As I said before, the tetracycline or doxycycline have two functions. It's an antibiotic and it helps improve the quality of the meibomian secretion itself. This is an additional finding that we found, that the tetracycline and doxycycline help to improve the quality of the meibomian secretion. So they improve it from being toothpaste-like or being inspissated secretion to revert it to the normal condition, which is oily-like secretion. Tear substitute. These patients have dry eye, so we are going to give them tear substitute in the form of eye drops. Topical steroids may control ocular surface inflammation. We said this is an inflammatory process, so we can give some topical steroid to reduce inflammation and help to revert the inflammatory process in the meibomian gland, revert it to a normal condition. Other new modalities in the form of topical cyclosporin. Topical cyclosporin, this is a drug that helps to secrete natural tears. It's not a tear substitute, it's a drug to help secrete natural tears. It is a very expensive drug, but it helps to improve the tear quality by increasing the flow or increased production of the natural tears. Pulsed light application. As you can see here, this is a machine that gives pulsed light that helps to heat the meibomian gland, helps to heat the oily secretion, inspissated secretion, to help it melt. This is like melting butter or melting cheese. If you are going to apply heat to this oily material that is inspissated and thick in nature, if it's heated, it's going to be again fluidy-like and helps to come out of the meibomian orifices. And then you can express the gland itself. As you can see, this forceps, when you press on the lid, it can express the secretions from the meibomian gland. This helps to improve the flow of the inspissated material in the meibomian gland, and of course management of complication. So now I concluded the first part, which is inflammatory and infectious part of the eyelid, which was the acute localized inflammation in the form of hordeolum internum, hordeolum externum, and the chronic non-infective inflammation in the form of the chalazion, and we talked about also the blepharitis. Now we're going to talk about lid malpositions. I'll be talking about the ptosis. There are several malpositions in the form of ptosis, lid retraction, entropion, ectropion, but we are going to now be talking about the ptosis. What is ptosis? It is drooping of the upper eyelid below its normal position. So what's the normal position of the eyelid? As you can see here, the normal upper eyelid covers about 1 to 2 millimeters of the upper part of the cornea. So the normal upper lid is not above the limbus, it's not above the cornea, it covers 1 to 2 millimeters of the upper cornea, okay? So that it covers more than 2 millimeters of the superior limbus in the primary position. What is the primary position? It is the position when the patient looks straight ahead to you. It's not looking to the side, not looking up, not looking down. The primary position is the position when I look straight into the doctor's eye or straight in front of myself. So if there is dropping of the upper eyelid, it's called drooping, not dropping. Drooping means sagging down. Okay, drooping of the upper eyelid below its normal position, which is about 2 millimeters of the upper part of the cornea. This is called ptosis. It should be differentiated from pseudotosis. What is pseudotosis? It is not true ptosis. It is something that looks like ptosis. What are the causes of pseudotosis? If you have enophthalmos, means the eye is small in size or it is retracted inside the globe. So as you can see here, this eye is smaller in size than this one. So this eye is enophthalmic or going more inside the globe. So here there is an apparent ptosis, but actually this is not true ptosis. This is pseudotosis. Redundancy of the lid skin. Here, this lid skin, this is redundant because the patient is old. This is called dermatochalasis or excess skin in the old age. This is not true ptosis. This is pseudotosis. Hypotropia. Hypotropia means the eye is looking downward. Tropia is squint looking down, and hypo is squint looking downward. So in this patient, this eye is looking downward and the upper lid follows. So this is not ptosis. If I cover the normal eye, this eye will pick up the normal fixation and will collect the hypotropia, and the normal lid will be in position again. So this is one cause of pseudotosis. The fourth one is contralateral lid retraction. So this eye is not ptotic. This eye is, the lid is retracted from its normal position. So this eye is not ptotic, but this one is lid retraction. So these are the causes of pseudotosis. So what about the etiology of ptosis? It can be congenital ptosis in the form of this picture. It's frequently sporadic but may have hereditary origin. It is due to lack of development of the levator muscle resulting in smooth lid with loss of the tarsal fold. You can see this is normal. This fold is perfectly normal. This is due to the insertion of the levator aponeurosis in the upper part of the tarsus. But due to lack of the normal development of the levator muscle in such congenital ptosis, you find here this is ptosis have no fold in the skin. So this is the congenital ptosis. The second type is paralytic ptosis due to the third cranial nerve, which is the oculomotor nerve. As you can see here, this eye is normal, but this eye has ptosis. The third cranial nerve supplies the medial rectus. So here there is paralysis of the medial rectus. That's why the eye is looking outward, because there is no muscle pulling the eye inward. It's paralyzed. And also the third nerve supplies the levator muscle, so this lid will be drooping. So if you have a lid that is dropping down below the normal position, please check for the position of the globe itself, because if you have a case of third nerve palsy, the ptosis is protecting the eye from diplopia. What is diplopia? It is double vision. Why there will be double vision? Because the patient has squint. Why does he have squint? Because it has paralysis of the medial rectus, and the lateral rectus is acting, so the eye, if this eye is looking straight ahead, seeing one object, and the other eye is looking to the one side, seeing another object. So this will cause diplopia. And what is preventing diplopia in such patient is the closure or the drooping of the upper lid in this abnormal eye. So if you're going to correct the ptosis for this patient, you're going to correct the ptosis, and the patient will start seeing things double. And they will start accusing the doctor, you caused my eye to cause diplopia. But actually the doctor did not take care that he has squint with the ptosis because of the third cranial nerve palsy. In such case, we have to correct the squint first, so that patient will have no diplopia when we correct the ptosis. The myogenic cause of ptosis, it is due to disease of the levator muscle. Example, muscle dystrophy, affection or muscle weakness. Okay, there are certain diseases causing muscle weakness itself, such as myasthenia gravis, and it is characterized by asymmetrical bilateral ptosis. It is more marked at the end of the day, after the patient is tired from opening and closing his eyes, so he gets tired, so we'll have to have the picture of ptosis at the end of the day. So wakes up in the morning quite well with no ptosis, but after being tired, ptosis will appear at the end of the day. This is called myogenic ptosis. Sympathetic ptosis, as we said before, the sympathetic nerve supply the hornal muscle. So if you have a Horner syndrome affecting the molar muscle, you will have ptosis. We discussed Horner syndrome. It is ptosis, and you see here there is ptosis. Meiosis means pupil is narrow, and anhydrosis, the skin is dry, and enophthalmos, or the eye is being retracted inside. So this is Horner syndrome. It's a syndrome composed of ptosis, as you can see here. Meiosis, this pupil is small, this one is large. So this lid is ptotic, this lid is normal position. There is ptosis, meiosis, narrow pupil. Anhydrosis means dry skin, and enophthalmos, the globe is retracted inward. The fourth one, or the fifth one, is called aponeurotic ptosis, and this is the most common, the senile ptosis. It is due to disinsertion or dehiscence, means loss of attachment of the levator muscle. It is usually with advanced age. You can see it after trauma or after ocular surgery due to stretching of the lid by the speculum opening the eye. Typically, there is good levator function. Okay, so this eye is ptotic, okay, and this one is less ptotic. But if you ask the patient to look upward, he will elevate the upper lid, but he has ptosis due to the disinsertion or dehiscence of the levator aponeurosis. We have also mechanical ptosis. Heaviness of the lid can cause ptosis. As you can see, there is a swelling in the upper eyelid here, causing heaviness, and this will cause mechanical ptosis. And last but not least, also the traumatic ptosis. How do we treat ptosis? Simply, there is surgical intervention in the form of levator resection. What is levator resection? If we expose the levator muscle, this muscle is weak, we're going to expose it and make it shorter. When you shorten the muscle, it will act more on pulling the upper eyelid and correct the ptosis. So shortening the muscle is called resection, and here we have to shorten the weak muscle, which is the levator muscle. This is why it's called levator resection. Sometimes the levator muscle is not functioning whatsoever, so we have to replace the action of the levator muscle by a sling. What is a sling? A sling is like الحمالة بتاعت البنطلون بتاعت إبراهيم عيسى, something that holds the pants just on the shoulder. This is the sling for the trousers. Here we have also slings for the eyelid. If we pass some non-inflammatory or non-irritant material and attach it to the tarsus and connect this knot to the frontalis muscle, so the patient elevates the eyebrow, he can pull on the levate or pull on the tarsus and elevate the upper lid. So again, if you're going to put a sling, something to hold the lid and attach this thing to the frontalis muscle, so when it elevates the eyebrow, it will elevate the eyelid. So surgical intervention in the form of levator resection and frontalis sling. We can have medical treatment for myasthenia gravis because this is a muscle or myogenic cause. We can have treatment of the cause such as mechanical ptosis. We can remove the cause of the swelling of the lid, and this will improve the heaviness or the weight being put on the lid. The second term on the malposition of the eyelid is called upper eyelid retraction. The sclera above the limbus should not be visible. As we said before, that the normal position of the eyelid is covering about 2 millimeters of the cornea, upper part of the cornea, in the primary position. So if the sclera is shown above the limbus in the resting position or the primary position, this is called lid retraction. You can see here the sclera is being seen all around the cornea in the right and left eye. You can see here in the right and left eye, and this is after treatment, this is before treatment, this is after treatment. This is called lid retraction. This is called scleral show. The most important cause of lid retraction is the thyroid eye disease. So what will happen if the lid is retracted? The eye will be exposed more to the environment around it, more to the air around it, leading to dry eye. Dryness can be severe up to the extent of corneal ulceration and sometimes corneal perforation and melting. Okay, I'd like to thank you. This was my lecture about the eyelid. We talked about the anatomy of the eyelid. We talked about the inflammatory process of the eyelid. We talked about some of the malposition of the eyelid in the form of ptosis and lid retraction. Hope you enjoyed the lecture and hope to see you in the clinical rounds. Bye bye.